So I'm Dr. Arsalla Islam, one of the bariatric surgeons in town, and I represent My Bariatric Solutions today. And we're going to talk about a lot of things. And I apologize, the slides are like probably 75. And I wanted to grace through some of the slides with you guys so that you can see how much research is going on into that field. And it's not just, oh, somebody's overweight because they ate too much. It is actually not the case. So let's get started. These are just the definitions that most of the providers kind of go by. If somebody's overweight, BMI of 18.5, underweight less than 18.5, normal 18 to about 25, but once the BMI starts more than 25, and if you're there, you want to start thinking about, okay, what am I doing wrong? What do I need to do? Because once you get about 70 pounds overweight, then you're too far beyond just diet and exercise. So, and of course, the patient that I mostly deal with are obese patients. You know, their BMI is above 31, 32, and they're having like diabetes, high blood pressure. They're prone to cancers, breast cancer, uterine cancer. So we're going to talk about all that today. So this is a very interesting topic about central obesity. If you Google obesity, you'll find, okay, pear shape or apple shape. So apple shape is basically what men usually get big. They get big in the belly, and women usually start getting big from the thighs, and they look almost like a pear. Now, what happens is that these kind of obesity patterns help us identify patients that are high risk for heart problems. Because if somebody has a waist of more than 40 in a man, that increases his chances for diabetes, hypertension, stroke, you name it. So, I'm going to skip over that. So I'm going to show some of the trends, and I'm not going to go over all of them, but just in 1992, about 15% of the patients were obese in those dark blue states. But look at the pattern now. 96, 2000, I mean, it's going to start growing. And now the red one is more than 25% obesity. And now more than 35% is maroon. And this is the latest. So we are actually, Texas is just a little bit behind some of the other states in the Midwest. So the South is about 32% obese pattern, and Midwest 32%, and the West is at least 26%. All right, so let's talk about this very important topic. So it really depends on patients that do become overweight and obese. If you look at their education level, they're most likely to be not more than high school. And that was something that we're going to play into genetics also. And it is like mind-boggling research that people are doing now, that people who are prone to being overweight, they're overweight because of certain genes interacting with their knowledge and their environment. So if you look at, and these are all self-reported. So maybe they're PPH, I mean, if somebody asks me how much I weigh, and if I'm a little overweight, I'll go with what I weighed like 2 years ago when I was probably smallest. So they're all self-reported data, and it actually looks a little bit better than actual data. So if you look at the non-communicable disease today versus 2030, you'll see that the longer bar is 2030 projection. And all of them, non-communicable diseases, if you look at it directly or indirectly, are either directly or indirectly related to being big, to obesity. So what are those problems? Liver disease, like fatty liver, non-alcoholic fatty liver, diabetes, heart attacks, strokes, cancer. I'm going to present you a slide on cancer, it's mind-boggling. Kidney problems, asthma, cognitive disorders, difficulty to concentrate, and diabetes is actually directly related to having high incidence of cancer. So if you look at these melanomas, thyroid cancer, rectal cancer, colon cancer, uterine cancer, breast cancer, meningiomas in the brain, they're related to being obese, a patient being obese. So what are the other problems that are associated? Arthritis, it kind of makes sense. Your joints are designed for somebody who is supposed to weigh 150 pounds, and you're 300. So every time you walk on your joints, your cartilage is going to rub, and it's going to wear that off. when you're in your mid-40s. It won't last you till your 70s. So that's an important thing. If a big person trips like this and they fall, they are going to bend in an abnormal fashion on an ankle or on a knee joint, and that's going to cause more injuries than a person who is ideal body weight or not overweight. And that is, it just makes it more worse. And they are going to be off from work, and you're going to need, extension on their disability. Migraine headaches, very common in females, but as we operate and they lose probably even 50% of their extra body weight, their migraine headaches go away. Let's talk about the venous stasis. If a big patient comes to me and they have varicose veins in the legs, if it's a big patient with varicose veins, the first thing I do is ask them to lose weight. Diet and exercise, with sometimes pills. If that doesn't work, surgery. And I don't even treat the varicose veins, which I also do vascular surgery. I don't even treat them. I don't even check for reflux in those veins, because that is so directly related to your abdominal fat. Your veins are pumping blood every time you squeeze your ankle. Your gastrocnemius muscle kind of squeezes that blood back towards your abdomen, back to the heart. But if you have a lot of belly fat, what's going to happen is that the vein is going to find a lot of hindrance going in that direction. So first thing first, you want to lose your abdominal fat. All right, next slide. So mortality. A patient that is big, even if they undergo a normal gallbladder surgery, is more prone to having an adverse outcome. Gallbladder surgery is bread and butter. We do it every day. It's half an hour surgery. Patients go home the same day. But if an obese patient undergoes that surgery, they're more prone to having complications, even death, from a DVT. So the patient's mortality goes high as they get big. Impact of childhood obesity. So kids who get obese, and you go to a mall and you see kids walking around and eating ice cream and not very healthy food choices and being big, that's child abuse. The parents need to know all this, because they are less likely to get married, less likely to get a higher education, because guess what? Overweight patients get depressed. That depression, lack of productivity, causes them to not attain their full potential in college. They're more likely to be unemployed. So that's something that we can probably start educating our society as to what is good for them, and we'll talk in a little bit. So weight bias. It is the third leading cause of prejudice next to age and race. So people who are big, they come in for a job interview to similar CVs, the person who's overweight probably will not get picked. And that's not me. I mean, this is data concise from people who are overweight. And some of these people were kids as young as 3 years of age. So they still feel that bias. What happens when they have that bias? They actually feel, and they actually have that bias from even siblings, from even parents, and educational institutions. And I gave that figure, about $29 annually. Healthcare facilities spend higher on big patients compared to normal weight patients. So what is that effect? How does that affect a human being? They get depressed, lower level of physical activity. They are at, I'm not saying all big patients are depressed, but they're at risk for depression, risk for low self-esteem, and they basically score less on any kind of standardized questionnaire that you would give them for bodily pain or vitality statistics. All right, I'm going to go over, so on the backside. So this is weight stigmatization, and we think, you look at some movies and there are jokes around it, and somehow society all over the world is somehow accepting it as, they're big because they overeat. They're big because they're not moving around. They're big because it's why don't you just stop eating, So that is actually not true. It is a notion that I'm going to start challenging right now. So when I got done with my training, as a bariatric surgeon in 2009, we did not have that information. And that is the information that University of Toronto and some of the institutions here in the US is actually taking a lead, and they're doing a gene research. And what we find is this, that there are genetic factors and biological factors and environmental factors. And they are confounding variables that come in and produce your actual body weight. And even if you do your best behavioral and dietary intervention, past a certain weight, and I'm talking about obesity, I'm not talking about somebody who's 30 pounds overweight. I'm talking about somebody who's at least 60 to 70 pounds overweight. They can probably lose weight, 10% of their extra body weight, and then just do yo-yo. They're gonna go up, go down, go up, go down. But every decade, they're gonna pile up more weight. So what have we learned? In 2008, they discovered 8 monogenic alleles on human genome that makes us more prone to being big. And there are several names over there. I'm not going to go over the details of those names, but just to present you the data, there's so much data out there. All these genes out there are confirmed make you more prone to being overweight. There's loss of function mutation. And there are some genes that actually, if they mutate, even if you eat a little bit more and exercise a little bit less, you're still not going to gain weight. You know how some patients come to me, oh, we have a sibling who eats more than we do, and they're very sedentary. How come I am going through this? Well, it's your genetics. So let's talk about this. Even the increased amount of intake. So some patients are more prone to eating. So of course, somebody gained weight not because, of course, they ate a lot of calories, and they did not spend those calories in those 24 hours. So the extra calories are going to get stored on their body for maybe a famine to hit, which never does. So what happens with this is that with some of these genes that get expressed, not in your teenage, not in your 20s, mostly in 40s and 50s. So they get expressed, and they're actually triggered by high-calorie diet. So if we had the diet from 150 years ago, less food, right? So less low-calorie diet, more vegetables, less food in general, we would not have those genes triggered. And now we do. So what we need to do is to decrease our intake, and we're going to go over that, increase our physical activity, and that kind of sometimes shuts off those genes. So how do those genes interact with environment? So high level of physical activity is associated with 40% reduction in some of the genes expression. So just for us to be more active and get out of that sedentary lifestyle, you'll notice that you're not eating that much. You won't notice it that day, but probably over a week or so, you'll notice, well, I'm going to gym every day, and I don't feel like eating that pie anymore. And that's because that gene expression is going down. It's all genetics. So it's our genes that are expressing in the hypothalamus that basically controls everything, our metabolism, and how we produce fat. So let's talk about, I'm going to skip over that because it's too much detail. So there are 3 therapeutic options. Of course, lifestyle change, pharmacotherapy, and surgery. And I'm going to just go say one sentence. All of these things are going to be successful if your genes agree with that. There are some gene mutations where you diet and exercise and they won't work. But we don't, at this point in 2019, don't have the capacity to check for it. A patient comes into the door and then get their human genome and check which genes are expressed in their hypothalamus and which are not. But that would be an ideal way to deal with the patients being overweight. Because some of them are going to do great with diet and exercise, and they're going to have great results. Some of them, if you have that gene mutation, you won't. Same thing about surgery. Most of the patients do very well with surgery, but there are some that fail, and they have that expression, a gene that is expressed in their hypothalamus that just makes them undo the surgery. How do we undo that? We don't exercise and we overeat. Of course, that's the balance we have to create. All right, so let's talk about the surgery. to this day, surgery, bariatric surgery is one permanent solution as best as we can have in 2019 to patients who are morbidly obese. If you follow their data, that's actually compared to lifestyle changes, compared to lifestyle change only, compared to pharmacotherapy. If you have surgery with diet and exercise, that's your best way to get rid of the extra body weight and keep it down. All right, so intestinal flora. That is a very interesting topic. We're still not doing fecal transplantation. So basically what is in works is that to treat diabetes, normal patients who are not diabetic, their fecal matter is taken, and it is, of course, they process it in such a way that the bacteria are left. It doesn't have to be very high volume, but it just gets transplanted into a patient who is diabetic. And guess what? The diabetes improves. It doesn't resolve all the way, but because we are changing the GI gut flora, all the bacteroides, they have an improved metabolic outcome. So fecal microbiota transplant is still in the works, and it actually does very well for diabetes control, but if you're full-fledged diabetic, it doesn't work very well. So it's more of a treatment for pre-diabetics. Of course, it's difficult to have volunteers who are going to poop every day for us, and also then to have volunteers that are agreeable to this treatment. But this treatment, if you think about it, has like minimal side effects. Actually, none were reported, except for they have to be transplanted anal route with all the fecal matter. But if you think about it, just changing the flora in the gut changes the way we metabolize food. So why is that? So let's talk about this slide. And I think this is the most interesting slide today. Why? The mode of delivery. If somebody was C-section versus vaginal delivery, it's going to impact their gut flora, and that's going to impact their adult body weight. If somebody was breastfed or not, if somebody was given formula, at what age were they given formula, then all changes the gut microbiota. And that all actually, in the end, all of these things are going to be adipogenesis, like fat deposition. Also, energy harvesting. How do you harvest your energy from food? Insulin activity. Insulin is an anabolic hormone. If I eat a cookie, well, considering I'm a normal human being, considering I'm not pre-diabetic, and somebody is diabetic or have insulin resistance, if they eat a cookie versus I eat a cookie, my insulin level is going to go here, and their insulin level is going to go there. And that cookie is going to make them gain weight because insulin is an anabolic hormone. Anytime. That's why when you eat an apple, the glycemic index, it makes your blood glucose rise slowly. Versus if you eat a candy that has same calories, the blood glucose is going to go up like that. That spike in the blood glucose is going to cause your pancreas to make a spike of insulin that's going to make you gain weight. That apple that has a low glycemic index is going to do this to your glucose. The insulin is going to also be tapered, like a very slow curve, and they will not gain weight that much. So that basically just started with all the antibiotics you got as a child, exercise as a young adult and kids. That's why it's so important to get kids out there and run around, especially as teenagers. Excuse me. Probiotics. I think to this day, what the data we have is that probiotics are really good for us. All that guts probiotics that, I don't know, Costco or Sam's have like a ton. Yes, they're good for us. Take like 10 billion a day. That's gonna actually improve the way you assimilate food, and insulin activity is gonna improve with that. So I recommend probiotics for my patients, not right after surgery, but like in longer run. All right. So what are we doing in 2018? 2019. That's the last year's slide. Diet, exercise, behavioral treatment, endoluminal therapy is just a balloon. If somebody's 30 pounds overweight and they really, because no insurance covers for it, so they really want to throw away some money also, yeah, get the balloon done. I mean, seriously. Because what's going to happen is that after 6 months, I'm going to come back and say, hey, you can't have it anymore because 6 months is the FDA-approved duration on the balloon. So it works only if you're really, really active and you're only just 30 pounds overweight. Yeah, get the balloon done if you really want to get that 30-pound weight loss within 6 months. You will probably get it if you're really motivated. But afterwards, you're on your own because 6 months later, I'm going to be back taking that balloon now. But it's not a surgery, you know, it's just a procedure that we go in through the mouth, do an upper endoscopy, versus surgical options, which are the best actually. So I'm going to go over the medical treatment, which we talked about yo-yo effect with just diet and exercise, especially if you're more than 60 to 70 pounds overweight. Before that, yeah, it works pretty good. So you're supposed to actually get about a deficit of 500 to 1,000 calories a day. If you can't create that deficit, it means you're not exercising. So you have to eat less and less amount of high calorie food, plus you have to exercise more to create a negative calorie balance. If you're not able to do that, you diet the best you could, but you're not exercising, you're not going to lose any weight, and you're going to get depressed after a few weeks. And you're going to go back to your regular eating habits saying nothing works for me. But yes, if you consistently seek a professional, you know, we have nurse practitioners that do the medical weight loss with us, and they're going to make a diet plan for the patient. All right, so this is also very important. If you have a cookie jar that you're trying to stay away from and not eat it, hide it. If you can see it, okay. So for example, there's a long bookshelf. On top of that, I can see a cookie jar, and chocolate chip cookie is my best, favorite cookie. And I have a cookie jar right here underneath my desk. So the first one is the top bar. So I'm gonna just, do my presentation, prepare for it, and then, okay, I'm done with my tea, so I'm gonna take a cookie and eat it because I really like it. So 1 week later, my cookie jar is empty. So that's that. It's proximate, it's right here, and yeah, it's visible right here. Now, if it's proximate and not visible, means it's right there, but it's locked in a drawer. I'll not think about it. If it's less proximate but visible, so it's over there, but I can, every time I type something and look up, I'm tired, yeah, that cookie looks interesting. I'm gonna actually make effort to go for that cookie jar. That's a third tall bar. So if you wanna not engage in some kind of food activity that's unhealthy, hide it. You should not be able to see it, because if you can see it, you'll actually get an effort to go for it. All right, weight loss is socially contagious. Find friends who are into weight loss. Find friends and family members who are really into gatherings with just grilled vegetables and turkey and water, and not anything other than that, And yes, I mean, you can probably do that, and everyone is gonna benefit from it. So the lifestyle adjustment is, of course, huge. Basically, we have to, in a nutshell, stay away from bread, pasta, rice on most of the days. Most of the days. As a treat, as a occasional thing, it's perfectly fine to do that. All right, so physical activity, we all know this, 1 hour of aerobic physical activity. If you're lifting weights for 10 minutes and you're tired, yes, you're burning some calories, but I personally don't like that kind of exercise. I like my patient, to actually get on a treadmill. If not treadmill, if they have bad joints, half of my patients have knee joints that hurt because they're overweight, I start with swimming. I want them to swim because that's one exercise that you can do and you won't be harming your cartilage. And you will be able to do that because your weight is supported by water. So one day, just 30 calories excess over a lifetime is going to accumulate 200 pounds. That is so interesting. 2 crackers is 30 calories. 2 saltine crackers, I think, is about 30 calories. So if you're not hungry, don't graze. Grazing that's why we say don't graze. Grazing is a bad habit because it's a habit you're just putting in your mouth. You're not too full, but that 30 kilocalories over lifetime is going to generate another human being worth of weight. All right, so I'm going to skip over all those. I'm going to go over surgery. Roux-en-Y gastric bypass, excellent operation, but the risks are twice the risk of this surgery, the sleeve, which is actually an awesome operation because it's laparoscopic. If your BMI is less than 50, you actually get to go home the same day. You get your surgery scheduled in the morning. We check you out after about 6 hours. If you're eating, if you're drinking okay, and you're walking okay, you get to go home that day. That portion of the stomach that we remove, about 80%, put in a bag and take it out of the body, is actually the ghrelin forming production of the stomach. What happens is that ghrelin is our hunger hormone, and ghrelin goes to the brain and it causes us to go seek food. So if most of the ghrelin hormone is gone, you don't get that hungry. Now this notion that we tell actually to almost all the patients has been challenged by some research that no, in some patients the ghrelin does not go down, but again, the capacity to store food does. So you're going to be on liquids the patient's going to be on liquids for a few weeks after surgery to make sure the staple line heals up completely. And they start soft diet. By the time they are on solids, about a month, they'll notice that patients eat about 1/4 of a cup and they're full. And they're full as if they ate a nice big meal. So we want to make sure that our patients are eating high protein diet and getting their vitamins in. That's duodenal switch, again, malabsorption, cause sleeve plus malabsorption. I don't think it's necessary for most of the patients. So this is like last few slides, the 30-day outcomes for gastric sleeve versus the Roux-en-Y gastric bypass. I'm going to go quickly over the details. This is MSQIP study. It's about half the risk of complications. 30-day mortality was 0.1% for sleeve and 0.2 for Roux-en-Y gastric bypass. Significant on that. But on the incidence of reoperation was about double, 1% versus 2%. Readmission rate, again, about double, 1.2 versus 2.8%. And same data from UK as well. It just tells us the same thing. So what works? A balanced approach to lifestyle change, support from friends, family is really important. Optimization of comorbidities means once patients lose weight, they will need a primary care physician to attend to their blood pressure because they're going to call you from the shower that, hey, I'm dizzy. Well, you probably need to taper down your blood pressure pills. So, we need a good, close relationship between surgeons and the primary care physicians. And we need something long-lasting, like surgical intervention. Somebody's big, they're prone to be big, that's why they're big. So you don't want to do something temporary. Questions? Yes?
So there's been a lot of contradicting, I would call it, publicity on the intake of alcohol. Several years ago, it was like red wine is good, and then now they're saying it's bad. I know it's been linked to some cancers. And
sure.
What about weight gain?
Okay, very bad. So even if it's like red wine or it's like $100 per like 20 ounce, I don't know, the way body metabolism looks at it is it's sugar, it's water, and it may have some antioxidants in some colored wines. That's it. So, and it's toxic to a smaller liver. So liver. So it means that for a female to consume the same amount of alcohol than a male, females are going to actually have more problems with weight gain and toxicity to the liver. So in terms of weight gain as such, yeah, alcohol is not good. Some of my patients who actually undergo surgery, lose like 100 pounds, they get some kind of addiction towards and propensity towards increased consumption of alcohol. Stay away from high portion food. Small quantities meals are great. So this is something that I've tried with myself also. What you do is you eat a little bit and you're still hungry and you want to eat that full thing. You ate half the sandwich and you actually toss the top off. So you eat the sandwich plus the one side of the bread. If you're not trying to lose weight, I'm just saying how to just maintain a healthy body weight. Toss the top off, eat half the sandwich. with some water, and then come back to it 2 hours later. What's gonna happen is that as you stay away from food, go back to your activities, see patients, or go pick up kids from school, your brain is gonna switch off that eating mode, and it's gonna go into the metabolism mode. By the time 2 hours later, you'll probably not even be hungry, to be honest. And if you are, about 4 hours later, just eat the rest of the half sandwich. So it does actually matter how much you're eating at a time. So that notion that, oh, I'm gonna not eat anything, not have breakfast, not eat anything, go home, then have a big giant meal at 5 p.m. Bad idea, bad idea. Why? Because your stomach is gonna stretch big, you're gonna not have any control on what you're eating, because you're gonna eat everything. You're gonna eat the whole house. All right, questions? Okay.